Hi guys, I'm Jackson from the Nurse Break. Thank you for watching and getting on live with this first attempt at running a live stream Q&A. So what you'll be able to do is you'll be able to see this live on Facebook. So you can pop down comments and I'll see them and I can ask whoever I'm interviewing. This time it'll be the Ben, but you can put your questions in comments. We can see them in live time. Let me know who you are. Are you a nurse? Are you a student? Where are you watching from? Where are you from? And let's get this show on the road. So, hey Ben, how are you?
Good.
Lieutenant Ben Jenkins. He is a registered nurse and a paramedic who is studied in Melbourne, I believe, and now he lives down in Queensland.
Yeah, up in Townsville.
Up in Townsville.
Yeah, it's all right.
Super happy to have you on board. Can you tell us a bit about yourself?
Yeah. So I've similar to where you are at Jackson. So I went through Monash. I did nursing paramedic double degrees. I went straight from Monash, and as part of that, I was very fortunate to receive a defence sponsorship through Army. So that was very convenient, and I very much appreciated that. I've come straight from when you finish your degrees, you then do 2 placement years before entry into the Army as a nursing officer. So in those 2 years, I did my graduate program at the Princess Alexandra Hospital in Brisbane within the intensive care unit, and then went and did a mix of both ICU and ED in that second year. And that's when I've now started off as a nursing officer in Army.
Very cool. So to be a grad in ICU, that's not super common to hear about.
No.
Yeah, how did you find that? How'd you get that role?
Yeah, exactly right. So when I was down in Victoria going for grad programs, I was going for my applications. Went to obviously all of the Victorian main sort of hospitals I was going for. At that time, they were a bit hesitant on putting grads in ICU. So I went up to, so it's part of the paramedic degrees the degree that I was doing. I used to compete for Monash in student paramedic competitions. So it just so happened that as one of the big tournaments of the year was coming up, I went up to Brisbane, competed in one of those, which was, I loved it, one of the best experiences of my time. But the very next day was the open day for PA. So I had already sort of mentioned and sort of emailed my way through and started talking about could I attend and all that sort of stuff. So I went along for the open day, absolutely fell in love. I knew straight away that was definitely where I wanted to work, and in particular ICU. And the way that grad programs work in Queensland, as opposed to Victoria. So in Victoria, you mainly have rotations. So you go through the 4-month rotations or 6-month rotations, and you go around those areas. While in Queensland, what really drew me to the particular hospital I was working at, and in particular ICU, I guess, is that you have a whole year within that area. So I knew that I would be working at the equivalent, like a major trauma centre in Brisbane. You would be working within intensive care, and at the very same time, completing a formal Queensland transition to practice program within ICU. So ticked every box, and I knew I was going to get a lot from that opportunity, and everything went from there.
So so at Prince Alfred, Alexandra, so what type of supports did you get as a grad?
Yeah, exactly right. So the particular program that they had at PA, they've had grads in their ICU for a very, very long time. And the clinical educators that they've been there for a long, long time as well. So there's such a nice structured program that they have there that they know exactly where you should be and at what level throughout the entirety of your grad program. So it was a very, very structured program. And again, that's one of the large reasons that drew me to working in that particular hospital within that area, because I knew the education that I'd receive would be superb. And it's definitely no lie that I absolutely loved that experience. And something I love about ICU as well, sort of mentioning this before we started the recording today, is that within ICU especially, every single step of the way through your grad program, you are allocated patients that are suitable to your skill level. So whilst, yes, this particular ICU I was working in had a lot of trauma, you had very, very unwell patients, but they're not going to start you off on a patient that's on ECMO or really severely sick patients within your first few weeks to months. You're able to really scale it as you go through. So as you're at the beginning of your grad program, And then when you compare that to where you finish right at the end, you look back and you just see just how amazingly far that you've just come. And you're not, and yes, it is a little bit overwhelming because of how fast that they sort of push you through and how hard they push you throughout the program. But I like that every time you come to work, the people allocating you to patients are able to allocate you to a patient that will be suitable to that position, and also put you next door to someone who would be able to really look after you, who's that more experienced nurse. So,
okay. So are you looking after ventilator patients at the start, or so lots of people think everyone in ICU is unconscious. That's often a common thought about ICU, but not everyone's unconscious in ICU. Not everyone's so what type of patients were you looking after at the start, and then what in comparison to at the end of your grad year in ICU?
Sure. Yeah. So the very first type of patients I was caring for, so I guess I'll sort of delineate it to say that before I even touched a patient during a preceptor, before I even started my own sort of time, you go through a preceptorship period. And before even getting in and having buddied shifts, they would have like a couple of, I'm pretty sure it was a little while, a couple of weeks of going through some education. So they would pull you off the floor and be, okay, for today and tomorrow, we're going to be learning all about mechanical ventilation, and we'll be talking to you about the pumps and the drivers and all of this sort of foundational things. And then as you sort of got through that initial time, that's when we're going to stick you with some with a buddy, and then you do that buddied shifts for however many shifts it was. I think I was very lucky, and I think I got 10 buddied shifts, which is huge. I think anyone listening who's probably gone through something similar, that's a long time. And during that time, it wasn't just caring for the particular patients that I would have been starting on. We're caring for patients who were very quite unwell, and some other patients that would be more at my skill level starting off. So you got to see sort of the types of patients coming through the unit. And the particular unit that I worked at, it was one of the highest percentage in Australia for patients who are ventilated to non-ventilated. So there were quite a significant amount of patients who are there who are mechanically ventilated. So it's very, like, when you first start off, and I hadn't had a student placement in ICU, so I had many placements in most areas of nursing, but ICU was one of them that I didn't. So I didn't know much about mechanical ventilation before starting off. So everything I was sort of learning, I was really paying attention during that sort of education type period, because I'm about to start caring for these patients straight away. And so it was. And so for those first few shifts, I started caring for patients who were ventilated. Just so happened that these patients were had a trachea, so it just means that they have been in the unit for quite a while. And so the normal progression is if you're having trouble weaning off a ventilator, usually gets to about that 2-week mark. And that's when they go from an endotracheal tube in the mouth to then making the trachea in the neck. And that's when they connect the ventilator onto that. So from the very start, I was caring straight away for patients who were on a ventilator. But the good part about it is that I'm next to nurses who are highly, highly experienced, and were there watching and helping me out the entire time.
Cool. Okay. Can you tell me what is a critical care nurse versus someone who is a nurse in ICU? What is the difference?
Yeah. So that's a very common question. That's a question that I had myself. So I guess it depends where you're asking in Australia. And I know how weird that sort of sounds, but when I say critical care in Victoria, then that's sort of the thought of it is going to be more of your intensive care and emergency, and more of your, can even push into CCU type stuff and HDU. But if you say critical care in Queensland, then that's more along the lines of HDU, ED. It's more ED type focused. So I guess it depends where you are and where you're talking from. The way I look at the critical care is definitely ICU and ED.
Okay. So if you guys are joining and watching us now, I've got Ben Jenkins, live Q&A. Chuck your questions down on Facebook Live. I've seen a few people have asked some questions, so I'll get to those a bit later. And just keep commenting down where you're from, are you a nurse or student, and any questions you have. Ben, before I get to that question, you started a podcast. Can you tell us a bit about the podcast and why you did that?
Yeah, exactly right. So the podcast is called New Grad Radio. So I started it off a few weeks into starting my grad year. And I guess a large reason was I always knew coming into my grad program that I wanted to sort of document it in some way. So my first few thoughts were I'm going to create a blog. And I knew that was something quite common. I saw a lot of people going through and they even in their student years, they'd start blogs talking about their experiences. But as I started those first few shifts especially, I had so much that I wanted to talk about. And as I sat down and was trying to write, I just couldn't get the feeling across. Like I felt like I was just trying to write these pages and pages. And I knew straight away that it's not going to be something that I could keep up and keep doing for a long time. And I've always been, like, for many years now, I've been a real big right into podcasts. And so I just happened to listening to one of my other favorite podcasts. He was sort of mentioning about this new app that's just been released, and it was called Anchor. And so what Anchor is, and that's what I've been using this entire time. It's a free app, and this is not sponsored by Anchor at all, but it's Anchor. The way it works is quite literally you pull your phone out, you open the app, you push record, you record your voice, push stop, put some basic comments and stuff onto it, and then bang off it goes. So it goes across all your major streaming apps. But I guess before I get there, like I guess I already wanted to sort of mention, even as I was going into my very first shifts, I had my clinical facilitator, who would be the nurse that's looking after the grads. And the main question I asked her was, hey, just a quick question, like, what are some things I could do right now before I officially start my first few shifts? And I'm thinking, okay, I'll get some ideas about some books on mechanical ventilation or some YouTube clips, or what's in your opinion that I could be doing to improve and to really get the next step and ready to go. And the one piece of feedback that sort of hit me between the eyes is she said, learn how to manage stress. And at the time, I'm just like, I did not understand what she meant at all. But again, I do now 100%. But as I sort of had those first few weeks, and before I even recorded anything, I knew that not only did I want to talk about intensive care nursing, because that's what the entire first season's about, following my journey of starting within intensive care, so everything from my first night shift to caring for my first vented patient, like all that sort of stuff. But it was more so also about what it was like and to feel normal, to feel a bit overwhelmed. I really wanted to also push in that sort of stuff as well. When I was having an awful day, I wanted to talk about it, just to normalize that wherever you're working, whether it's ICU, ED, anywhere within your area, that we're all learning that we all have bad days and we all have great days. And it's really important to talk about those bad days just as much.
Yeah, 100%. Self-care and stress management. I've had a few people write blogs actually for the Nurse Break on those topics, and they're not often the most popular articles that people want to read. You know, everyone writes about that, everyone talks about that, but it's actually the burnout rate in nursing is very high from what I've seen. What are some of your other favorite blogs that you'd recommend people to watch, to listen to?
Yeah, so one of my favorite that I've
not blogs, podcasts.
Okay. Yeah, no, I got you, mate. That's fine. I remember every single night shift, I lived close enough to work that I'd walk to work and walk back from work every single day. And so during that 15-minute sort of walk, I would always be listening to podcasts nonstop. So my favorite medical type podcast is called The Resus Room. It's one that I know you've heard of there, Jackson, but the Resus Room, the whole premise is that it's run by two emergency doctors, and they have multiple different segments within their podcast. So you'll have like of January, for example, they might break down 3 different journal articles, and they sort of critically appraise those articles and talk about what has come of that research. But then they also have other segments, which is called Roadside to Resus, where they bring in an intensive care paramedic. He'll talk about that particular topic, let's just say hypothermia. They'll talk about it from the pre-hospital perspective, what paramedics do, and then they talk through the stream into getting into the emergency department and talking about what they do there. And then they might go to the next step and then talk about what happens in the intensive care unit. So for all of these different topics, whether it's pediatric cardiac arrest or whatever it could be, there's so many podcast episodes I have now, but with all these different segments, it's just effortless learning as you're walking off to work. But otherwise, some of my other fun ones I like listening to on the side, you got the NASA Johnson Space Center talking about obviously space and NASA, but they also have segments within it talking about healthcare. So one of the latest ones they're talking about right now is what are the challenges that doctors and medical specialists are going to have when they try to get these astronauts to get to Mars. So anyway, I'm a bit of a nerd when it comes to podcasts. I love them, but there's too many to choose from. But they're two of my favorite, I guess.
Oh, cool. I've got 2 questions I'm going to pop up quickly, and we've got a few others later. Matthew has asked, you must have not been listening, Matthew. What is the name of your podcast, Ben?
It's called New Grad Radio, Intensive Care and Emergency Nurse. Yeah, so I've just started up. Yeah, it's all right. Just started up the 3rd season now. So the first 2 seasons, the first one was all about intensive care nursing. And then I switched into that second year into the emergency department. So the second one's mostly ED, also talking about, that's when I started doing interviews. And the 3rd season I just started, which is breaking down the fundamentals of intensive care nursing. So this is for those ward nurses who are being upskilled to get into intensive care, and to break down everything from a fundamental level.
That's amazing. So if any of you are doing that free medcast, ICU 20,000 nurses around Australia can get onto it. I definitely recommend you hop onto Ben's podcast. He'll give you some really good insights. Another question we've got is from Lawson. Lawson asks, speaking of stress management, what has Ben found? And his second comment was...
That's a really good question, Lawson. Thank you so much for that, mate. Yeah, so this was not something I did well to start with, I guess. It's all throughout uni, I was pushing very hard and trying to achieve a lot. And with the defense sponsorship allowed me a lot of time in order to push into a whole bunch of areas that I thoroughly enjoyed, whether it be starting up new programs or mentoring and teaching and all this sort of other sort of stuff. So I went through a level of just constant stress and trying to achieve as much as I could for so long that I got into my grad program, and I'm coming into a really high stress, high expectation environment. And I sort of like even the basic stuff I talk about when one of the first sort of episodes talking about trying to give a handover. And I got, and this was probably the most, and even now, like I look back on it, it's probably the most straightforward patient I've ever had in intensive care. This was so straightforward that it was a patient that got discharged from intensive care home, which you'd think like that never happens. And that was the only ever patient that I've ever had that's had that. So we're talking real fundamental. And I got a couple of sentences into my handover to my clin fac before it came to the actual nurse that's going to take over. First opportunity I had to try to give a handover. Few sentences in, I broke down crying. Like it was just everything from those first few weeks felt so overwhelming. And that's the level of stress that was just there. So starting in ICU, like, yes, it's exciting and you're learning a whole new bunch of skills, but it is stressful. So what did I find? I found that taking those times to and from work to be listening to these podcasts especially helped. Just trying to, that's why I started listening to not only the Resus Room, which is all just med focused, but also listening to things like this NASA sort of podcast and everything, just trying to, all right, let's get some exercise in, let's go to work. Something that I enjoyed doing, I was a bit of a weirdo from my other nurses. I used to get up at like 2:30, 3 o'clock in the morning to go to the gym because I knew that was the time of day that there was no one else in the gym. I could throw as many weights around as I want. That was my time. I got to have that time. And I'd be going to bed super early. I'll take some time to sort of just do some foam rolling and some stretching in the evening, just playing some calming music, just other thing. And then and then as time sort of went on, I started sort of meeting some new people because I moved from being in Melbourne to Queensland. Trying to meet a whole new bunch of people and a whole new bunch of friends isn't easy. So I've started to sort of go out with some sort of people that I was sort of meeting at the time. And that's when that sort of started to have me time that little bit more. But again, that's what I try to really portray in this podcast, is that it's not always easy and that it's normal to feel a bit overwhelmed.
Cool. Really good advice. I've got another question for you. What makes a great ICU nurse? Yeah, so there's you often hear things like you need excellent grades and you need to be really academically inclined, and because it's such an intellectual thing. And in one hand, yes, you're taking on such a large amount of information from the very start and expected to apply that to a very critically unwell patient. So yeah, it is intellectually just stimulating, and you're needing to just keep up, and that's what's pretty hard about it. But I guess the side of ICU that I felt really passionately about talking about on the podcast, and even now having a chat about what makes a good ICU nurse, is I see it's all about how you relate to not only your patient, but your family members. Again, PA, where I was working, it's a trauma center. You've got patients coming in with traumatic brain injuries. You've got
people coming in and the types of injuries bringing you into intensive care can be just life-changing for your patient and their family. And it's a very high stress, but also just highly emotional environment. Here you are, like here I was a couple of weeks in and a couple of months into starting, and here I am being in a family meeting. Now, what does that mean? A family meeting is when you have the doctor, a social worker, and the nurse caring for that patient at that day come into a room, and you have the family members there, and that's when we're updating about the current status of that patient. So you can, especially there came some periods of time there where just as my grad program went on and I'm starting to care for more critically unwell patients, that you're going in quite consistently into these family meetings, and it's just the level of emotion that comes into these rooms is not something that I ever really comprehended until I started. So to me, what makes a good ICU nurse, yes, you could be as intellectually engaged as you like. You could be all over ventilators and hemodynamic monitoring and all that sort of stuff. But I think at the end of the day, it really comes down to your interpersonal skills and how you can really build that relationship with the family members and the patient.
Yeah, amazing advice. Having worked about 6 months on trauma myself, I saw some really sad situations, especially when the family members come and a reality check is given to them. Do you have you seen, I guess, those family meeting conversations? You've seen some good ones, I assume. Have you seen any that just don't go well?
Well, I guess that's what's so dynamic about it as always, is that every family is going to take it differently, and everyone comes from different backgrounds, and everyone just processes things differently. So it's I guess the feedback that I received when I first started, and this is just I loved the feedback from my nurses all around me. So I'm a naturally positive, energetic person, and yes, that's great when I have a bit of a chat to people and it's all good, but that's not always helpful within those types of situations. It's not nice to portray a level of positivity within such a negative and emotional time period. So some of the feedback I started to receive pretty early on when this all started to happen, and not necessarily in family meetings, but just in the general day-to-day care of these patients, is that I was told I was giving false hope. That's pretty as blunt and straightforward as it could get. My terminology and then the words I was choosing to use didn't accurately reflect on the severity of the situation. So
can you give an example, for example?
Not
a patient example, but some of the words that you would.
When the family members would sort of ask, like, how are they doing today? I said, oh, look, they're doing really well. Basic. That's like straight right there. Like,
yeah.
And no, like the patient is overall, like when I say that, I'm meaning well, like I meant well when I said that sort of stuff, but it didn't accurately reflect that, they had to be, like, I won't go into specifics, but it's when the patient is at that stage where it's that they may die, that it's not great to be leading with things like they're doing well when no, they're not. So I had to sort of go, and the way I sort of used the strategy I used to come into that was the more that I started to understand my job and to understand the progression of patient care within ICU, I started to learn those strategies on how to communicate more effectively. And sometimes, this is something that I sort of danced around as a student, but something you get a lot better at within ICU, caring for these patients day in, day out, is that sometimes it's better to be straightforward. It really is. It's sort of like just matter of fact type language. Not saying, that you never say, they're going to die. Like that's obviously not the case, and that's not the right thing to say. But it's more along the lines of, they're not doing great today. Like just the facts. If you stick to the facts, and the most of the time I started to learn that's what families just appreciated more.
Thank you for sharing that. Do you think, as a student, you were really prepared for ICU, or do you think that students should aim to go to a general medical ward or other wards before, rather than go straight to an ICU? What's your advice?
So there's different ways of probably tackling this sort of question. It's I'm very passionate about that. If you're dead set keen about starting in intensive care, then there should be no reason why you can't start in intensive care. It's probably the most negative feedback that I've received from starting the podcast and just publicly displaying that I've started my career in intensive care, and I've started my career within a major trauma centre's intensive care. And the most common feedback I'd receive from just negative type feedback, I don't receive a lot of it, but when I do, the sort of feedback is I highly question the decision to put a grad within intensive care. And then they can start to go on to a whole big rant about some time that they saw some particular student do something, or like whatever. Like that's your opinion, and that opinion to you means something, and that's fine. But I hope that I was able to portray through the New Grad Radio podcast over these last few years that it's very possible to start within intensive care. And if you've got the right supportive team and the right educators, and you are taking it very seriously, then there's no reason whatsoever that you can't start. I guess the most common piece of feedback that I guess the opinion that people have about grad starting in ICU is that you miss the fundamentals of what you learn when you start within a ward setting. Now, to this, I can see a point. And I guess in a way, I knew that I was going to transition from my time, the 2 years, and then into my new role as a nursing officer in the Army. So I knew that I had 2 years to learn as much as possible to then enter this new career. And so I knew that I wanted to, like my thought process was like, not every patient that I'll be caring for in the Army is going to have a breathing tube in their mouth and going to receive that level of intensive care. So that's why I decided to go from intensive care into emergency. So in order to develop a more broader skill set, to then obviously into this new role, which I loved. And just seeing again, funny little things. I used to think like, if I'm not going to get into intensive care, I'm just going to get into emergency. And it's, I can't stress enough of just how different those areas are. Like it's very light and day between intensive care and emergency. And it was challenging going from ICU to ED. But yeah, I guess, saying that though, like I felt like I built a lot of those skills going from ICU to ED, more of the time management, being able to care for multiple patients and being able to be a bit more dynamic and flexible in that way. Because ICU itself is very structured. Like, you know that every 3 hours that patient's going to be turned. You know that that medication will be due at this time and that you'll be doing these cares, and it's very structured throughout your day. And that's done that for patient safety, so you never miss anything. But then you go into emergency and everyone calls it like your controlled chaos, and it's just very different type of nursing. But I felt that ED was able to provide a lot of those fundamental cares that these nurses are alluding to.
Okay. And before we went live, we chatted about pool nursing, because something I'd like to get onto myself. And what's your understanding of pool nursing? You had quite a few good comments about pool nursing. What advice do you have to people, registered nurses of experience, or students who are thinking of what is pool nursing, firstly, and secondly, what benefits can that give you as in your clinical experiences?
Sure. Yeah. So I hadn't been exposed to pool nurses really within intensive care. The time I was exposed to was in emergency. So when most days I'd turn up to work, I'd find that there'd be pool nurses in ED. And that's when I really was able to start talking to these nurses about what exactly you do. And what I really appreciate about pool nurses is that they, in a way, they have it rough, because they'll, like, unlike if you're working in ED, if you're working in ICU, if you're working in a ward, you get to know your team members really well. You get to know the processes of what that unit does and their clinical guidelines and everything. Like, you know that unit inside and out. But what pool nurses have to do is that they have to be able to turn up, not know where they're going for that day, get told that you're going to here today, and just be flexible and dynamic enough to then step into their, to start with, I can imagine when they first start their careers, it's a matter of, okay, let's learn their processes. But over a matter of time and experience working on the pool, and you often see a lot of the nurses that I've worked with have been in the pool for a long time. And so what they love about it, what they cherish about their job, is that over that time period and working in all these different areas, that they become very knowledgeable in a large amount of ward nursing and a whole large areas of nursing. So the skills that they're able to develop is incredible, and the knowledge that they can draw upon come into another unit, and then they might be showing things in a way that unit has never experienced yet, because the other ward does it that way, but this ward has never seen it that way. So I often find them this excellent link between the wards. They provided a different experience to other people. So highly recommend it if that's an area that you're looking at doing, then I think they do an excellent job.
Really good advice. Now, you've mentioned a few times that you're now in the Defence Force as a nursing officer. Can you explain to what is the process? I know there's two processes. You can either be an experienced nurse or you can be a student. Can you sort of just briefly explain the options and how that application process works for anyone who's interested?
Yep. So I guess I'll preface this real quick by saying that my views reflect my own and not those of the Australian Defence Force. So to start off with, so like yourself there, Jackson, like you received a defence sponsorship. So if you're coming in as a student nurse and you have finished your first year of nursing, then you can apply for the Defence University Sponsorship Scheme, which pretty much says that at the end of your first year, you go through the recruitment process. So that's going to your first U session, which is you contacting the defence recruiting. You're going in there and saying, hey, I'm interested in doing this. You go through your colour deficiency tests, and you go through basic sort of written exam and a few other little hoops in that regard. You then go to an assessment day if you get through that one, okay? And the assessment day is more of a formalised interview process, I guess. You go through that level, and if you get through that, you get to an officer selection board, and that's can't really talk about too much what happens there. They try to tell you to keep it nice and hush-hush, but it's pretty much it's a full process of having to deliver presentations and such and such. But once you go through there, you might get said, yep, cool. We then will endorse you to say, yes, we believe that you have what it takes in order to be a nursing officer. And from those people that they say yes to, then they select a small portion of those people to then award them the Defence Sponsorship Scheme. So, and what that involves is that you get from the time that they sponsor you, they pay for your university subjects, and they also pay you a wage and give you some rent allowance and a few other little goodies here and there. To then knowing that every year that they sponsor you, that you're going to offer those many years plus 1 year's back. So that's for undergraduate sponsored. And then you can come into it with already being a registered nurse. They say that you need 2 years experience as a registered nurse before you can start applying for a direct graduate entry into defence with whatever service that you go into, whether it's Army, Navy or Air Force. And once you are in, just understanding that whilst your job title is a nursing officer, the environment that you'll be working in as a nursing officer in Army compared to Air Force compared to Navy, and the officer training that you receive is quite different between all of those ones. So you're operating obviously in different environments, and the level of training that you receive is different compared to each. So yeah, they're the two main ones. You've got graduate or undergraduate entry.
Okay, very cool to hear. A little bit of a change of pace. So for a student on placement,
yep.
Ian or Aaron, what advice would you have to a student to ace placement, to really go well, get really good grades, make a really solid impression?
Sure. I guess similar to theatre, I had multiple theatre placements coming through. Very similar to theatre. Within intensive care, the way that you approach a placement there is quite considerably different than what is going to be used to within most other areas of nursing on placement. Now, what do I mean by that? So if you come into an emergency department, you've had a student placement there, you'll start noticing pretty quick that your buddy in those first few shifts are going to obviously get a lay of the land. You start understanding the process of what you need to be doing. And each patient's you need to put them into a robe, you need to get 12-lead ECG and all that other sort of stuff. You start getting to know the process. The same in the ward. You turn up to a ward, you know that in the morning, you're going to be getting these patients up and these are the times of medications and blah, blah, blah. So you can be actively involved and you can start having that level of critical thinking, and then you can have a patient load. As opposed to those other areas, the way that intensive care will work for students is that, yes, you have an expectation of understanding what's happening, kind of, but it's mostly, and what's hard about approaching a shift in there for a student is going to be, you're not going to be as hands-on directly taking care of that patient. Instead, you're there a lot of the time to observe, and that's quite different mindset than what you're probably used to with most other placements. But the students that I've had and the students that my colleagues will have that we say, oh, you've absolutely nailed it. They're the students that want to get in and be involved in the assessment process. So what I always sort of will sort of really push for my students is to be like, in intensive care, it's quite normal to see things that are abnormal. The how unwell these patients are has what brought them to intensive care. Like, you start seeing things that you won't be able to really see anywhere else. So you start to see when we have someone so heavily sedated and that their urine starts turning green. And it's kind of like you don't see that. You know what I mean? Like, it's different. Yeah. And this is the time in which you're going to be able to formalize a proper GCS. So I don't mean, okay, turn into the room and someone's looked at me spontaneously and they're either confused or they're not. You know, I'm like, in this case, you've got someone who could be heavily sedated, and that patient could be coming off, like, had a traumatic brain injury that brought them there. And you are seeing patients who are decorticate posturing. You are seeing patients who are withdrawing from only their left arm. So we're talking like you're getting real good at GCSs. So, and then also like little things like patient assessment wise, you're listening and auscultating to lung fields. Like, you are pushing onto the abdomen and feeling if it is rigid and distended, because could be if they're coming off of surgery. So it's your patient assessment skills, I'd say, is the area if you could really be focusing on within your time in intensive care, and really getting in there and showing your buddy that you're willing to get involved and to really step in and to help, then that is what sort of, in my opinion, is going to be setting students apart from the others. Now, the first thing that, again, I know when I come into intensive care that I really want to get good at the ventilator. And so that's often the thing that students will really want to ask. I want to know all about the ventilator. Tell me everything about it. But it's and that's normal to feel that way, because I know that if I came in, I probably would have been that way too. But I think what you'll start seeing is that there is so much to intensive care that you can't take on everything. But I think the thing that's going to be transferred, like, and learning about the ventilator is great. I've made episodes in this latest season of New Grad where it talks about the ventilator and the absolute fundamentals. So if you're interested in learning more about that sort of stuff, great. I've talked about that. But I think what's going to help set you up the best to not necessarily just work in intensive care, but to go anywhere in nursing, is the types of systematic head-to-toe assessments that you'll be getting from your time in intensive care.
100%. That, along with advocating, and the only little other part of advice I would say to students would be, at the start of your shifts, you need to introduce yourself, tell us what year you're in, what are your objectives for the shift, and have some objectives before you start your shift. And just show your interest, because we look after many students, and often after a while, we don't know who you are, which university you're from, what level you're at. So just having that conversation really help build a relationship for the rest of the shift. I've got heaps of comments. Thank you guys for posting your questions. Keep posting them. We'll get to them. Hopefully you have some time, Ben.
No, that's all right. I'll go for it.
Alex has asked.
G'day, Alex. How you doing, mate?
I've been out of ICU for 12 years and out of the hospitals for 4. I've been in primary healthcare recently. Would it be too hard for me to return back to critical care? Alex, thank you for asking the question.
We'll see for sure. It's intensive care is one of those areas that we have. Thank you very much for asking it, Alex. I guess every person's experience is going to be different. What I find fascinating about intensive care, and this is when it comes back to should grads start in intensive care or not, there are internal, this is probably a little bit off. I promise I'll get to the message, I promise. Everything here. But when you first, I guess there's a program specifically in there's called like the critical care rotation program, for example. You have emergency nurses who have been ED nurses for 15 plus years who have decided, okay, I'm going to just do something else. I'm going to come and work in emergency for 3 months and then come back. Those guys, because you get so set to your area, they find it challenging to then step into this whole new world of intensive care nursing. It's the same as if you step into another area. But I've seen physically like nurses from all different areas who have never stepped foot into intensive care. So it's a bit different to what you're mentioning, Alex. But you have nurses from all different areas coming into it, and you can have numbs, you can have all sorts of people. But what I found as intensive care specifically is that it's such a different environment. that everyone struggles. And that's what I really wanted to emphasize with this podcast, is that it's normal to not feel completely on it. So whilst your area that you've been in intensive care before and that you've built those fundamentals, and whilst you've been out of it, at least you will coming back into intensive care knowing some of those strategies that you've used yourself. Like you've had some previous experience to base something off. But whether you are experienced coming back into it, or whether you're a grad coming in, or whether you're a nurse from a different area about to step into it, I guess just having the ability to just leave ego at the door, to be able to come back in, and whether you're working next to a grad nurse who's 8 months into their program, or whether you're working next to someone who's been working in ICU for 20 years, that everyone has something to be able to help. That grad nurse who may have only been there for a few months, like they've been there for a solid amount of time now. In the grand scheme of things, no, but in that time that they know that unit, they know the processes, they've been caring day in, day out for these unwell patients. So being able to ask questions when you don't know, being able to escalate things appropriately, and being able to just leave ego at the door, I think are some of the most essential things to working with in intensive care. So I have no doubt that you couldn't come back into intensive care, but just being able to be like, you know what, I haven't been here for a while. I'm willing to just feel as if you're starting again, willing to just get involved and help the team wherever possible, and just never being too shy to ask for help. I'd say that's probably the
advice. Alex, I hope that answered your question. Well, I've got
send another question. It's all good.
Yeah, we'll go to a few more questions, and I'll go to talking another one for you myself. Chanel. Hey, Ben, your thoughts on completing crit care qualifications in ICU versus ED? Is one department better than the other? Thank you, Chanel, for asking that.
That's a good question, Chanel. I guess when it comes to, so I find that intensive care nurse, and this is me, this is only coming from my experience and my opinion, but I found the process of going from intensive care to emergency, it appears as if that transition was a lot easier than what I find that emergency nurses going into intensive care. So the skills that I've developed within intensive care, being that real systematic systems assessment, and feeling comfortable with having patients who have a whole bunch of weird wonky numbers, and having patients who are so dynamic, and then being able to really use your equipment and your assessment abilities. And then whether that's just caring for that one patient, but then that can be directly applied into having 4 patients who are nowhere near as unwell, but you know what sick looks like. So when you come into emergency, you know when to escalate things pretty soon on. You know what patients, even though you don't get really great to start with, and that's something I found challenging, is that now going from one patient that I know everything about to now having technically 3, but I might have up to 7 patients if my buddy goes on break or off to CT or whatever. But having the ability to have that systematic approach, knowing when things don't go quite well. So I know I've worked in both areas now, but I know for me, I'm about to do some extra training within intensive care, because I enjoy that area. I enjoy understanding things a lot more, and I found that I'm able to apply that into emergency just as well. So I don't think you're going to find that one is better than the other, but in my opinion, I thoroughly enjoy knowing a lot about my patients and feeling comfortable in that regard. So I hope that sort of helped in that regard. But I guess when I start, I was sort of mentioning this to you before, Jackson, about as you progress, and I think you even started this podcast talking about just now, or this video, talking about when you're starting off and you're going through your intensive care training, that the person can give you patients for that day and put you next to someone of experience that are suitable to your level every day for the entirety of your program. While in emergency, we can have grad nurses starting off in ED, and even experienced nurses starting to get off. And let's just say that you've been an experienced ED nurse for a couple of years now, but you haven't managed patients with arterial lines before, or you haven't managed patients who have had a lot of tracheostomies or other areas, things that in ICU you do all the time. And you can't just say, okay, you've got Chanel who's working in bed spaces 14, 15, 16. You can't always be like, hey, look, I know I can give you this patient, because that's suitable to your level right now. Instead, you can just get chucked anything with an emergency, and that can make it challenging. So Anyway, I'm probably getting off topic there, Chanel. I hope I've answered your question about different qualifications. But again, when you're going for specific, just have a think what you want to get from your postgraduate qualifications. If you're wanting to really get subspecialty within that area, so if you do a grad cert in intensive care nursing, then you're going down a very specific avenue of just intensive care, but you're pushing now near towards like if you're wanting to get down the gadgets point of view, you want to get into ECMO and nitric and some of the things that are real specific to intensive care. But if you go more of your critical care specialty, it's not going to be as specific to that area, but it's going to be more generalistic around the process of intensive care, of critical care. But then you go grad cert in emergency nursing, and obviously that's more very specific to emergency. It's going to touch on areas that you can also do within ICU. You're going to be going on to do with hemodynamic monitoring and more of your advanced ECGs, which you do in ICU as well. But I guess with that piece of paper that you're having in the day, just trying to think of what you're trying to use it for. I guess that's probably the biggest piece of advice.
Wow, okay, really, really good advice. Before I go to another question on it, I'll talk about the Australian College of Nursing. So the Australian College of Nursing can you tell us about it and your role in as a member of the military community?
Sure. So ACN in a whole, I like to think of it as I guess a community. I guess like other people can look at it as you got to pay money to it to be able to be joined as a member. Great, like that's one way of looking at it. But I see it as a community of nurses who are all coming together in order to benefit the nursing community as a whole. It's so ACN. Why did I sort of join and what's my role within it? So at the beginning of this year, I've started up their podcast. So I've now been hosting my new grad radio, but I've started in January, the Australian College of Nursing podcast, ACN podcast with Ben Jenkins, MACN. And I've also taken on a leadership position within, they have these particular subgroups within ACN called Community of Interests. And you have community of interest for all sorts of stuff. You can have cosmetic nursing, you have ACN's community of interest for what I'm a part of, which is the military nursing community of interest. But where like you've got disaster health, you've got a whole bunch of areas. But what they are is sub-communities that you can be a part of. And it's great because they're obviously within an area that excites you and of your interest. But it's also providing you with other people that have the same interest as you. And those leadership positions in there. So, for example, I'm the communications coordinator for this military nursing community of interest. So I'm pushing content out that would be of interest to this military nursing community, and have sort of meetings, and we're talking about the projection of where we want to take it. Obviously, before COVID and everything, that's obviously changed a little bit, a few plans. But then again, you then have all these community of interests. You're getting actively involved. You're meeting people of all different levels and experiences, from student nurses up to professors in that particular area. And then it all culminates by you guys coming together at the big ACN conferences they have each year. And that's where it's like a big celebration for nursing. It's absolutely incredible. But yeah, I guess ACN as a whole, like I've thoroughly enjoyed being a part of it. And I felt like it's a strong community of people that want to make a difference within nursing. But even with ACN, you've got, but you can do grad certs, you can go and do professional development, you can go and obviously go to the conferences, and they've got road shows where you can go and be part of it. I look at it kind of like CrossFit. You're part of a box, like you're there being part of a team together. But anyway, I'm sort of getting off topic, but I'm enjoying my time with ACN.
Yeah, no, really good advice. And it's great that you've been doing the Year of the Nurse and Midwife as well, 2020. What a year.
Yeah, that's right. Yeah, it's one of the large reasons for this podcast as well. So the ACN podcast is a fully interview format. So I'm interviewing nurses from a whole bunch of different subspecialties. So one of my very first ones was with Professor Deborah Jackson, who's the Dean of Nursing at Johns Hopkins University over in the US. So she's from Australia and she's gone over there talking about leadership. And then also coming in and, hey, Cara, how are you? And then also talking about a whole bunch of, so like one of the other nurses who's been a nurse for over 30 years as a nursing midwife has then come and then transitioned into politics. I'm talking about nursing and politics. So I'm just trying to touch on all these different nurses who are able to display what is possible with your career, and to show just how enormous of an opportunity is as a registered nurse and the things that you can go off and do.
Amazing. And that's exactly what we're trying to do here as well. Jess Keys, she has asked a massive question. I don't think it'll pop up on here.
No, that's all right. Go for it.
Let's try the top part of it. Have you ever been a patient in ICU, or have you ever looked after family members or friends, or know of them who've been in ICU?
How many colleagues who've had this experience?
It's a long question.
I did, but honestly, I'm a bit worried. Some past experience may impact my work. Yeah, no, that's a very deep question. I very much respect that question, Jess. It's for me, have I ever had a family member in intensive care? I have had a family member within intensive care. That was my grandma, but I've never had direct care of that patient. And then obviously you wouldn't be caring for that patient if they were your family member as a registered nurse. But you'll see some of the nurses some of my best mates as nurses have had family members who have been in intensive care. And that may have been before that they were nurses. That was a large reason for them entering nursing. I guess with intensive care, and I hope I've sort of stressed that within this episode, is that you could be as intellectually forward as you like, but I guess something that I never knew, and that's something I really wanted to show and share with people, was that intensive care is an environment that it isn't for everyone. And it's not because you're not smart enough. It's not because it's hard, too hard in that sort of way. If you have the drive, you can work in intensive care. But I think that's something that takes people off guard a little bit is just how emotionally taxing it can be to work in intensive care. And I know for me, especially when it came around the Christmas period, and at the end of my grad program, at the very end of it, it culminates with you do these transition books as part of this transition program. So these books which are theory loaded, and your big final assessment is going to be a CPAT, what they call. So it's a clinical performance appraisal test, I think. I don't know. But it's a whole day where you are not only caring for this very unwell patient. The expectation was a day 0, day 1 traumatic brain injury, or a day 0, day 1 out of hospital cardiac arrest. So both of these patients are exceptionally dynamic patients. They're very, very unwell. We're talking for a TBI. We have patients who obviously had a TBI. Their intracranial pressures can be very dynamic. Patients having a DECRA, so bone plate removed. You've got intracranial monitoring going on. A lot of these times you have to really be careful with their pressures because you can get pupillary changes, and that's obviously increased pressures in the brain. You've got to keep blood pressures within certain management, and there's a whole TBI protocol for what you're going by in order to really get them through this really unstable period. So that was the type of patient that was my CPAT patient right at the end of my grad program. So what I'm getting to is that in the lead up to that final CPAT, I had weeks upon weeks upon weeks of the unit giving me patients, which is very how it's supposed to be, giving me patients of this same demographic of patients day after day after day. So I'm going into family meetings day after day after day with patients family members who have just found out that their loved one has just had this significant injury. And obviously they're very unwell at this time. So you can imagine going into family meetings every day and having loved ones being told that, it's going to be a marathon for their recovery. It's very emotional. And you're doing that every day, it can start to weigh on you that little bit. And it can be quite emotionally draining, especially as it starts to get over that Christmas period as well. So that's trying to be raw and authentic with you with this answer. But that's just the reality of working in intensive care. That I think it takes you to be pretty strong, and it takes you to develop those coping mechanisms, I guess, as I was sort of trying to mention at the beginning, and having some people to be able to talk to, especially, is really important. So, it's, again, working in ICU, very different. I haven't personally cared for anyone else's family members or whatever, but it can be a very challenging environment, ICU.
Cross fingers that never happens. I've got another question for you. Is from Anna. This will be our last one for questions, guys. But what we'll do is, if you keep posting them down after this video, if you watch this in a few days, we'll hopefully be able to get Ben to answer them. Anna asks, interested to know, Ben, did you ever consider being a reservist, and why did you choose full-time rather than reserves?
Sure. No, that's a really valid question, Anna. I guess what we just mentioned before with talking about avenues into defence, I've only mentioned full-time options, that you do have this whole other land, which is the land of reserves. And again, you can have nursing officer reserves for all three services: Army, Navy, and Air Force. The role of a nurse within reserves is the same, like you are a nursing officer. You parade instead of working Monday to Friday like I do now as a full-time nursing officer. Instead, your full-time job is to be a nurse wherever you want to be, your normal job, except you parade, which means you basically turn up to a training night for which you go to the unit, and then you are parading as a nursing officer. And then typically when it comes to deployments or when it comes to doing tasks, or I know as you've probably seen with the bushfire relief, like a lot of those reserve nursing officers are the ones that were called upon in order to go and respond to those types of emergencies and responses. So for me, I knew pretty early on that I wanted to be a full-time nursing officer. Obviously you had the defense sponsorship, and that was an avenue of getting into that. So that's a large reason for why I chose it, because I knew that was going to be guaranteed entry into getting into full-time, which again, I'm thoroughly enjoying my job and I'm really loving the experiences that I'm gaining from it. But I guess for someone that doesn't want to step out of their specialty area, that reserves is an excellent opportunity to gain excellent training, to be able to get opportunities to travel and to be able to go and do your job in all different areas. So I hope that sort of answered your question, but yeah, I'm very thankful that I've joined full-time.
Anna, post down in the comments what you're thinking. Do you want to join the Defence Force? I believe you're a medical student, so are you thinking of the medical route as a doctor? We can I can get someone on and interview a medical officer for the Defence Force. So post down what you're interested in. My final question for you, Ben, and I'm so glad that you came on today, is
thank you.
For you, what's the future of Ben Jenkins?
Sure. It's I guess now it's just sort of trying to figure out my new space of my new role as a nursing officer in Army. It's obviously a very, very different career path, stepping out of being an intensive care and emergency nurse for the last 2 years, and going through the double degree. So you got the paramedic sort of stuff there as well. But and then stepping into this new role, it's an exciting new avenue of this. So I'll continue to be working in my spare time on other things that bring me joy, which is these podcasts, and especially like my new grad and ACN. But who knows? I think that's what's so exciting about it, is that there are so many opportunities within nursing, that there's so much that you can be doing. And so we'll see where it comes next.
Great. Do you have anything else you'd like to share before we go?
It's, no, I guess if just having a think, if you're a student now that you're considering what you're wanting to be doing as a registered nurse when you first get into your graduate program, just have a good think about what brings you joy. I know it's probably the most stressful time period when you're applying for your graduate positions. And even if you don't get into the area that you're really hoping for, let's just say that you really want ICU, like you really want ED, just really stressing again that it is very possible to be getting into that area once you gain some experience within your area that you do find yourself in, that it's very possible to switch over to the areas of what you're after. It just may take a little bit of time, or some people it's sooner than others, but it's don't be disheartened if you don't get the area straight away, because it's very possible to get into the areas that you love.
Great advice. I love the positive attitude. Guys, thank you for joining on the Nurse Break today. Thank you, Ben, for coming on during today's beautiful weather outside. I don't know how this went from everyone watching on Facebook. This is the first time I've done it. I'm sort of trial and erroring this. So if you have any advice on what works, what you want to be, whatever you'd like to make this better, really, send the Nurse Break a message on Facebook, send me a message, put in the comments. I'm going to get some really other interesting people as well, just like Ben, and I look forward to having you back on again in the future. Sure. Thank you for joining.
Thank you very much.
Thanks, Ben.